So today we shall be talking about Parkinson's disease with a special emphasis on the recent advances in its management. Just a glance at its history. Way back in 175 AD, Galen gave a description of the shaking palsy. And an essay of shaking palsy was written in 1817 by a London physician by the name of James Parkinson. But it was later on by Charcot who actually gave the name Parkinson's disease to this disease, which was earlier known as paralysis agitans or shaking palsy. And it was not till 1959 that the cause of this disease was actually attributed to the deficiency of dopamine in the brain. Later on, it was discovered that there are certain genes whose mutations are also responsible for causing certain types of Parkinson's disease. And the prevalence of this disease is around 360 per 100,000 population. The incidence is around 18 per 100,000 population. The disease gradually increases as people age. In India, the prevalence is much less than in the Western countries, and its maximum prevalence is seen in the Parsis, in the Western areas of India. And it's seen that most of the people who are suffering from Parkinsonism, we shall see the difference between Parkinsonism and Parkinson's disease in the subsequent slides. So it is seen that the maximum cases of Parkinsonism are because of idiopathic Parkinson's disease. So the term Parkinsonism is basically known to refer to the disorders which produce abnormalities of the basal ganglia functioning. And they could be of, it is a constellation of symptoms basically, which is known as Parkinsonism. It could be because of idiopathic reasons in which the cause is actually not known, which is also known as Parkinson's disease, or it may be secondary to some other disease processes. For example, some lesion involving the basal ganglia, like calcifications of basal ganglia, infarcts or hemorrhages in the basal ganglia or the like. And there may be certain Parkinson plus syndromes in which the symptoms of Parkinsonism are present, along with certain other things, for example, severe autonomic disturbances, cerebellar involvement and the like, or supranuclear palsies. So these are the Parkinson plus syndromes, like multiple system atrophy and the progressive supranuclear palsy. Now, before coming to the main topic, let's see what basal ganglia is basically connected to. Basal ganglia has connections to different areas of the brain, including the cortex, and it is connected by certain pathways, and these are divided into direct pathway and the indirect pathway. An important feature is that direct pathways, on the whole, it is excitatory in nature, and the inhibitory pathway is in general inhibitory in nature. Indirect pathways inhibitory in nature. Different functions of basal ganglia involve planning and programming of movements, which is the most important function because it inhibits and is excitatory to certain specific motor pathways. And then it is also involved in cognition and also plays a part in the motor memory, especially. For example, if a person has to learn how to ride a bicycle, then probably basal ganglia functioning would be important. The striatum has this is basically seen in most of the books, in the standard textbooks, that the striatum or basal ganglia, portion of the basal ganglia like putamen, is involved in movement because of its connection with the sensory motor areas of the cortex. Dorsal caudate area is related to the associative functions, and so the cognition, it plays an important role in cognition. The limbic areas are connected to the ventral striatum, so this portion plays an important role in emotion and motivation of a person. Once we cut sections of the brain of people who are suffering from this disease, we find that the substantia nigra portion, pars compacta area of the substantia nigra, is the region which appears pale in the patient suffering from this disease. So the pathology may vary from anything like neuronal loss, the gliosis, pigment accumulation, and then certain inclusion bodies, including the Lewy bodies, which are basically structures, the inclusion bodies seen in certain areas of the brains, like the neurons, and alpha-synuclein, which is basically a protein, a ribbon-like protein, which is, when it is misfolded, it is accumulated in certain areas of the brain, and it may interfere with the functioning of these areas. And so this alpha-synuclein is also seen in the pathology of the people suffering from Parkinson's disease. And not only Parkinson's disease, it is also seen in people who are suffering from Alzheimer's disease. Certain other areas of brain may also be involved apart from the basal ganglia, like certain regions of the intestine and cardiac plexus, the dorsal motor nucleus of vagus. So these are the other areas which may also be involved. Now, a major portion of our presentation deals with what is already known, or what is old, or what is already existing information about Parkinson's disease, and then what is new, or what is the latest about Parkinson's disease. Most of the research into what is into the recent advances, it arose when we came to know about the alpha-synuclein protein mutation, which is a common gene which is responsible, protein which is mutated, gene mutation, seen in patients suffering from Alzheimer's as well as Parkinson's disease. And then there was something known as Braak staging, which has been quoted by many people. And in this, it was found that substantia nigra involvement occurs not in the initial stages of the disease, but rather it is the involvement of the anterior olfactory nucleus, the medulla, and the pontine tegmentum, which is seen even before the involvement of substantia nigra, which is a trademark for this disease. And this is followed by the involvement of various cortical areas of the brain. So we see that there is an accumulation of Lewy bodies and alpha-synuclein mutations in the areas of the brain, like the anterior medullary anterior olfactory nuclei, pontine tegmentum, medulla, and even the cortical areas apart from the substantia nigra. These are the figures showing the alpha-synuclein, which is normally is in the form of certain ribbon-like structures. It's a protein which is folded into ribbon-like structures, and when there is a mutation, then it may accumulate. And then these are the Lewy bodies seen inside the cytoplasm of these cells. Causes could be several, leading from genetic causes, which are important in some young onset Parkinson's disease cases, and certain environmental factors like the involvement of pesticides, etc. Now, these are debatable things, and twin studies show that genetics may play an important role in causation of Parkinson's disease. The clinical features of Parkinson's disease are usually characterized by asymmetry in the initial stages, and later on there is an involvement of both the areas of the body. There could be decreased arm swing, shoulder pain, and rest tremor in one hand. So it's often people come to us, they forget to take into account the tremors which they are experiencing on one side of the body, but some of them may simply notice that they are having pain in the shoulders. Some of them may even present like a frozen shoulder, and after treatment from the orthopedics, they may be referred to us. So it is the shoulder pain is quite important feature, distinguishing feature of Parkinson's disease. The diagnosis could often be delayed if it is the non-dominant hand which is affected first. The tone could be increased. Now, the kind of increase in tone is the rigidity, which means that there is a resistance to motion which is felt both in the agonist as well as the antagonist muscles. This leads to either cogwheel kind of rigidity or the lead pipe kind of rigidity. Now, cogwheel rigidity means that if a person is, as if we try to do the passive movement of the limb, for example, the wrist joint, then we'll find that first there is an increase in resistance, then decrease in resistance to movement, then again an increase. So alternating increase and decrease in resistance occurs, which means that the feeling is similar to as if a person is walking on a cogwheel. And there is a lead pipe rigidity, which is often seen in the lower extremities, which is a rigidity seen uniformly throughout the range of the motion. Tendon reflexes may be increased, decreased, or normal, so they don't give a clue to the diagnosis of Parkinson's disease. An important feature is bradykinesia. Now, as we shall see in the subsequent slides, this has been considered to be the gold standard thing, which is a feature seen in all the cases of Parkinson's disease. So it could be a bradykinesia, which means that there is a slowness and difficulty in maintaining movement, or it could be hypokinesia, which means that the amplitude of movement is actually decreased. Now, for demonstrating hypokinesia, if we ask the person to do the movement of moving the this opposition of the thumb and the index finger fast, then it will be seen that gradually the person who is suffering from this disease, gradually this motion, the range keeps on decreasing. So this decrease in range or the amplitude is actually hypokinesia, and then the slowness which the person experiences and difficulty in maintaining movement, this is actually known as bradykinesia. The movements are reduced in speed, range, and amplitude. Now, it's the other things like psychiatric features, like even depression can also influence this. So that has to be distinguished. And in the later stages, the person may experience things like even the absence of movement at all, which is known as akinesia, or the freezing of movement. Now, this is important. If a person keeps on, like a person is walking on the road, for example, they may freeze. They may suddenly feel that their feet are glued to the ground, and they may find difficult to keep on continuing that movement. Micrographia is again a very disabling symptom of Parkinson's disease. People, because of their small and shaky handwriting, they may find that most of their bank checks are rejected. The bradykinesia per se is the most disabling symptom of Parkinson's disease. Tremor refers to the involuntary oscillation of a body part. Usual range of Parkinson's disease tremor is frequency is between 4 to 6 hertz. It's a resting kind of tremor, which is the gold standard for this disease, but they may experience certain other tremors also. For example, the postural tremors or even the action tremors. And the pill rolling kind of tremor of the hand, in which there's a movement of the thumb and the index fingers and the other fingers in a way as if the person is rolling a pill. So that is the standard of Parkinson's disease. The tremor may also be seen in forearm, jaw, tongue, and even the lower limb. They may be rest tremors. And an important feature is that the Parkinson's tremors, they almost completely disappear during sleep. People may have postural instability, especially in the later stages of the disease. So this is characterized by narrowing of the base of, so people may walk with a very narrow base. They may keep their feet at a very less distance. And unlike some other cases, like in normal pressure hydrocephalus and some other diseases in which the base of the walking may be wide. Now they may have, when a person keeps on having certain attentional demands, which means that if we ask the person to calculate along with moving, walking, then they may find to have it difficult to continue in this multitasking. Doing two tasks together would be very difficult for them. Now, they may experience increasing difficulty during walking, turning, reaching out to objects, and in the later stage, there may be falls. Though if the person is having falls very early in the disease, that is against the diagnosis of Parkinson's disease, and is probably a feature of some other diseases, related diseases like probably progressive supranuclear palsy. People may, in the later stage, there may be flexion of the trunk, and it is found that the person's maybe the body may be flexed, the upper limbs may also be flexed, and the posture may be stooped, and they may even be turned to trunk may even be turned to one side, which is flexion and turning to one side, which is particularly known as camptochomia, will be a feature of this disease. When people walk, As we already know, they may stand on a narrow base and their stance may be stooped. They may find it difficult to start walking. The gait may be a festinating in character, which is a very characteristic of Parkinson's gait. Now, it is characterized when the person, when we see such a person walking, we may find that they gradually increase their speed. They are flexed in forward direction. The stride length is decreased, and it may feel as if a person is trying to catch his or her center of gravity. They may tend to fall. It will feel as if they are running in the forward direction. There is a thing called entropulsion or retropulsion, which is seen in these people. So if we try to do a pull test, and if we pull the person in the forward direction, they may, instead of being able to balance themselves by maximum 1 or 2 steps, they may tend to walk in the or maybe run in the forward direction. So that is known as entropulsion. Similarly, in the backward direction, if they are pulled, they may try to walk. They may have to take more than 2.5 steps in the backward direction to prevent fall. And sometimes in the later stages, they may even fall without, when their balance in this function is absolutely gone. The freezing episodes can be triggered by confrontation of competing stimuli, and it is seen that they may even have certain flexion contractures in the later stages. So this is a diagrammatic representation of what a person having Parkinson's disease looks like. So initially, this is what an old age person would look like, a normal person, and his signature would look like this. And in the later stages, a person, in the person who is having Parkinson's disease will be stooped in the forward direction. So this is flexion of the trunk we can see here, and some flexion of the extremities will also be seen. And then their handwriting would be changed dramatically. So it would be very small, micrographia we can see in comparison to his earlier signatures, and they may be shaky. So the tremors would be there, and the movement in the signatures have absolutely changed. Now, they may have difficulty in swallowing, and they may be choking. There may be difficulty, and so because of that difficulty in eating, their nutrition may be significantly impaired, and they may experience weight loss, fatigue, and things like that. Then because their voice may be slow. So what ultimately happens in a person who is suffering from Parkinson's disease is that their voice slows, their movement slows, and even their thinking slows, a term which is known as bradyphrenia. They even think slowly. And ultimately, in the later stages, they may be absolutely silent or mute. Certain non-motor, we were talking about all the motor things till now, but there are certain non-motor features also which are important in these people. So they may have a mask or expressionless face. They may be experiencing loss of motivation to do certain acts. Learning may be difficult. They may be experiencing psychiatric disturbances like depression, anxious mood, and they may be having difficulty in sleeping. Cognition may be affected, and then they could even be experiencing hallucinations and delusions. Now, hallucinations per se are more often seen when once treatment is started for these patients, and the dopamine, this dopa agonists are most often the notorious agents, but sometimes the disease per se can also, they may be having hallucinations. Another important feature is the autonomic nervous system involvement. Now, this may even occur before the disease characteristic motor features of the disease appear, especially in the form of difficulty in smelling, the smell. And then orthostatic hypotension, the cardiac features may also be seen, and they are usually they are usually observed later on in the disease. Certain other things like pupillary responses, the GI disturbance. Now, constipation is a very important symptom of this disease. People may experience constipation for several years before this disease actually comes to our attention. And we have seen that the BRCA staging, so that may be, though it is a controversial thing, but that may be one of the reasons why people do experience constipation before the other symptoms appear. There may be urinary bladder dysfunction, sexual dysfunction, this dandruff and things and similar other features. Airway obstruction may occur in the later stages, and there would be venous pooling. The things like restless leg syndrome are associated, and excessive daytime sleepiness are associated with this disease, or maybe with the treatment which we give. They may experience vivid dreams, and then an important feature is pain in different areas of the body. There could be restlessness, but an important thing is that though people may be experiencing paresthesias, but often there is no objective. For the diagnosis, we have these recent criteria given by the Movement Disorder Society. So in this, bradykinesia or slowness of movement is the thing which is must. It could be either with rest tremor or with the rigidity. For clinically established Parkinson's disease, we need to have absence of absolute exclusion criteria and at least 2 supportive criteria and no red flags. For clinically probable Parkinson's disease, we need to exclude the exclusion criteria. And if at all we are having red flags, so they have to be counterbalanced by certain supportive criteria. Supportive criteria include a clear and dramatic response to the dopaminergic therapy. That is a must. Then there could be certain on-off phenomena, presence of levodopa-induced dyskinesias, and olfactory loss or cardiac sympathetic denervation. Exclusion criteria, we have to rule out the cerebellar involvement, the downward supranuclear gaze palsy, which is a feature of progressive supranuclear palsy, cerebellar involvement, which is a feature of multiple system atrophy, and then diagnosis of probable behavioral variants. So behavioral disorders have to be ruled out. And if the Parkinson's features are restricted to lower limbs for more than 3 years, that could be a feature of vascular Parkinson. So these come under the absolute exclusion criteria for Parkinson's disease per se. And then the treatment with if there is no proper response after giving dopamine, that usually rules out the disease. For documenting a good response to levodopa means that at least 30% to maybe 50% improvement in the symptoms after giving levodopa. Cortical sensory loss and documentation of some other condition, alternative condition, that has to be ruled out before diagnosing a person as labeling him as Parkinson's disease. So for diagnosing, as we have seen, history plays a very important role in the diagnosis of most of the neurological disorders, and Parkinson's disease is no exception. Examination has to complement the findings of the history. You have to rule out other causes of Parkinsonism, then CT and MRI for ruling out the secondary causes, and PET and SPECT for certain research areas. What are the red flags in the diagnosis of Parkinson's disease? Most of the things which cast a doubt on the diagnosis of Parkinson's disease are the red flags, like the prominent or early appearing memory loss, symmetrical signs, bulbar dysfunction, early appearing gait disorders, falls, early autonomic symptoms, and things like alien limb phenomena or cortical sensory loss or apraxia, which are more importantly a feature of corticobasal degeneration. So these things come in the red flags for the diagnosis of Parkinson's disease. Now, we already know what is Braak staging. So the study of biomarkers is probably based on the Braak staging, which shows that there are certain biomarkers which may appear in the preclinical stage of the disease when the disease is restricted to the areas of brain like the olfactory areas, medullary areas, etc. And then there could be certain biomarkers which would appear in the prodromal stages and rest would appear in the clinical stage itself. So things like hypoosmia, REM behavioral disorder, and autonomic features like constipation, hypotension, sexual dysfunction. So these things may appear even before the main features of the disease, the motor symptoms of the disease appear. Depression. Certain other biomarkers maybe like the presence of uric acid, low uric acid levels. Now, uric acid is an important antioxidant. So the low levels of uric acid are is quite good biomarker for diagnosing Parkinson's disease in the initial stages when the other symptoms have not yet appeared. Then there could be the chemical biomarkers like uric acid, certain proteins, coenzymes, homocysteine levels, and oxidized protein products, etc. And then there could be certain proteins which are basically accumulated in this disease, like alpha-synuclein, the tau proteins, amyloids, etc. And then there could be things like microRNAs and certain genetic biomarkers like Parkin, which is quite important in the young onset Parkinson's disease, DJ1. And then there could be certain radiological biomarkers like the presence of transcranial sonography and MRI. So these could, and the imaging which could show decrease in the functioning of the areas in which the dopamine is, from which the dopamine is secreted, like the substantia nigra. For diagnosing which stage and then prognosticating, basically finding out what is the response to treatment, this Hin and Ya's scale is quite important. And these are the different stages of this scale. So basically it is that initially there is an involvement of one side of the body, later on both the sides of body are involved, and this is followed by the involvement of postural reflexes. And further on, the person becomes confined to the wheelchair or bed. So it's basically a disability scale, and this is its modification, which is more often used. And there are certain other rating scales, like the presence of SHAB and England activities of daily living scale, and UPDRS, the Unified Parkinson's Disease Rating Scale, which is very often used to characterize the disease and find out how the response to treatment following the drugs which we give. Most of the clinical features can hence be divided into those which involve the motor areas of the brain, that is the motor areas, and those which involve the non-motor functioning, like cognition, for example. And then there is certain thing, once we start treatment, especially with levodopa or the dopamine agonist, then there is something like an on-off phenomena which results. So initially a person would be having a very good response to drugs, and later on as the disease progresses, the off stages may result. So the drug levels may be there in the blood, but the person may not get relief because of the drug. So that is an off stage. And after certain times, these on-off stages may appear in a very erratic fashion, which means that initially they would be off phases would be appearing after probably 3 or 4 hours of taking levodopa dose. But later on, they may appear at any time. And person may be experiencing peak dose dyskinesias, certain abnormal motor movements, which may appear when the person is having a full good drug level of levodopa or its agonists. These could be very troubling things for people. The treatment of Parkinson's disease can hence be divided into strategies which involve the use of drugs, which involve the use of certain surgical techniques, or those which involve the lifestyle modifications, the exercise or rehabilitative approaches, such as natural remedies, and even the things which are neuroprotective in nature. So what is already known about the drugs is the carbidopa-levodopa combination, which is gold standard for treating Parkinson's disease, dopamine agonists with a similar action like and almost similar side effects like carbidopa-levodopa combination, then monoamine oxidase inhibitors, B inhibitors like seleginine, razagiline, and safenamide, which is a new drug in our kitty. Catechol or methyl transferase or COMT inhibitors, which prevent the peripheral degradation, which prevent basically the degradation of levodopa so that its action lasts for a longer time. Anticholinergic agents, anticholinergic agents are quite interesting in that the level of acetylcholine and dopamine is, they act in a reverse fashion in the brain. So if the level of dopamine is more, then the level of the effect of acetylcholine may be less. And if acetylcholine is more, then the effect of dopamine could be less. So a person who is having anticholinergic, if we are giving anticholinergics, then probably they could be benefiting by increasing the action of dopamine in the brain. So dihexyphenydyl and benztropine are the agents which are used in this regard. Amantadine is a drug which has several mechanisms of action, an important one being action on the NMDA receptors. And then this table shows the mechanism of action of the known, quite often used drugs for Parkinson's disease, and important side effects of anticholinergics being dry mouth and urinary retention, which may be very troublesome, especially in the old age. Those of levodopa, important ones being nausea, vomiting, hallucinations, and even orthostatic hypotension. That of dopa agonists being again similar to that of levodopa, of MAO-B inhibitors, things like blurred vision, arrhythmias, and sleep changes. Of amantadine, things like swelling of feet and dizziness, and even hallucinations. Those of COMT inhibitors, things like hepatotoxicity and orange discoloration of urine. So the recent things, the things which are not so old, include the intrajejunal levodopa pump, which is now available. So the drug is absorbed in the jejunum and ileum, and hence it is less affected by the food intake. And intrajejunal infusion of levodopa is also there. And then there is a long-acting levodopa preparation, which is important for reducing the off periods. So drug will be, there would be a continuous level of levodopa, and then it would surpass the off periods, which are quite troublesome to the people. So the usual scenario is that a person has taken a pill in the morning, he or she is doing his or her day-to-day work, and after a certain time, while doing the work, the person realizes that suddenly he's experiencing an off effect. And so the entire functioning is stopped suddenly in the office or at the workplace. So to avoid that, the long-acting levodopa preparation is quite helpful. The modified form of levodopa soluble tablet is also helpful. It's a soluble tablet, so it's helpful for, it again takes care of the motor fluctuations to a certain extent. A subcutaneous levodopa belt pump and things like patches, the skin patches are coming up. A trigel is thing, the levodopa carbidopa gel is in clinical use, and things like trigel are also coming up. Now trigel is a combination of levodopa and this carbidopa along with the entacapone. So it again, and in the presence of entacapone means that the drug will stay for the action of levodopa will stay for a longer time. Inhaled levodopa powders are coming up, and then safanamide is available in India. It again has been found to increase the on time without troublesome dyskinesias. The nasal spray of apomorphine is coming up, and apomorphine pens are coming up. The pumps and injections, so all sorts of things are there now. And apomorphine pumps are useful to take care of the motor fluctuations. Now, apomorphine is a thing which has a very fast onset of action. So, in a person, if so, the usual its benefit is seen in those situations in which, like, a person is walking, he or she is there at the airport or maybe a railway station. They are going somewhere and suddenly they experience certain off phenomena. So what does a person do? He or she is paralyzed immediately. To avoid that, a person's caregiver may give the subcutaneous injection or maybe use this apomorphine pump, and its onset of action is in minutes. So the person resumes his or her activity very fast. So that is the major benefit, though the side effect is nausea, which is quite troublesome. So some pre-medications with the anti-nauseating agents may be needed. And it also, and then long-acting things with a duration of action of around 14 to 16 hours, they are also coming up. Now, this adenosine A2A receptor blocker are the things which are new agents. They have a newer mechanism of action, unlike the agents which were available till now. And they are useful for reducing the motor fluctuations, the off periods. They may worsen the dyskinesias, however. The extended release capsules of amantadine are available now, and intravenous amantadine again is available, and things like the research molecules like AV101 have been found to reduce the levodopa-induced dyskinesias in non-human primate models. So several things are researches are coming up. Now, opicapone is an agent which is similar to, of the same class as entacapone, and it is found to reduce the motor fluctuations. The difference is that it has a longer duration of action, so it needs to be taken only once a day. Droxidopa is a noradrenaline precursor, again useful for motor and non-motor freezing. So there are very less drugs which are available for freezing. So this could be important. Pimavanserin 5-HT2A inverse agonist. So its important role is in non-motor psychosis. So the non-motor things like psychosis, for that it is useful. Then there could be certain disease modifying therapies like the involvement, those things which target the alpha-synuclein protein synthesis, or which prevent the accumulation of these abnormal proteins, which prevent the degradation of certain neurons. So, and then things like active and passive immunization, which target, in which there are certain vectors which are introduced in certain areas of the brain similar to the immunization process. So these therapies have been found to be useful mainly for the motor motor problems in the management of Parkinson's disease. Caffeine, things like nicotine also may have been studied. Urate. Now, uric acid or urate is an important thing. It is a very, it is interesting molecule, as it has a great antioxidant properties. It may even prevent neuronal degeneration. So, as a disease-modifying agent, this is quite promising. Now, glial cell-like derived neurotropic factors and have been shown to have found, people have been found to get improvement in their putamen scans, though clinical improvement is yet, the studies are not showing clinical improvement. Nilotinib is an agent which was initially being studied for the treatment as a tyrosine kinase inhibitor. So it is basically a drug for the management of leukemias per se. Then Michael J. Fox Foundation showed interest in taking this molecule for research purposes, and it has been shown to reduce the alpha-synuclein levels in the rodents and increasing the autophagy. So it may again have certain role. Donepezil. Now again, for non-motor fluctuations, things which are non-dopaminergic, like donepezil, which is already used for the management of Alzheimer's disease, for the memory problems. So this has been found to be useful for Parkinson's disease, dementia, non-motor falls, gait disorders, and the like. And for the non-motor symptoms like pain, duloxetine, which is already used for certain neuropathic pains, may have a role. And things like oxycodone or naraxin, they are also being tried for the treatment of pain in Parkinson's disease. Minocycline, which is an antibiotic, has also been found to have certain role. And the reduced form of coenzyme Q10, the coenzyme Q10 was found to be ineffective in the trials, but the reduced form of coenzyme Q10, the ubiquitin, that has been found to be useful in lessening the symptoms of wearing off in those patients who are already taking levodopa. Nanotechnology, which uses certain nose-to-brain drug delivery systems, is being tried, and rotigotin is one molecule which is being used in this regard, tried in this regard. the surgical therapies nowadays, they are being used. So the deep brain stimulation is a very important thing in this regard. For it is basically a neurostimulation of a particular area of the brain, which is found involved in Parkinson's disease patients. And it is found to be useful in Parkinson's disease people once they start to have doubtful effect, once they start to develop certain side effects or adverse events related to levodopa use. So normally a person who is taking levodopa is, or the dopaminergic agonist, is happy for 5 years or more. But later on, certain troublesome things like peak dose dyskinesias, they start appearing because of the intake of levodopa, and the off phenomena that starts appearing. So the effect of the drug becomes very erratic. So in those stages, the deep brain stimulation is a thing which is quite helpful, and it can stabilize the medication fluctuations. It can reduce or halt the dyskinesias, and it can reduce tremor, rigidity, and improve even the slowness of movements to certain extent. The deep brain stimulation of subthalamic nucleus and globus pallidus internus is usually used for the motor symptoms of Parkinson's disease, and thalamus and globus pallidus for the may be helpful for the dyskinesias per se. Now, deep brain stimulation is being used at many centers all over the world, including in India and including Sanjay Gandhi Postgraduate Institute of Medical Sciences. And it has been found to be not useful for problems which are not but it is not useful for problems which are not responding, for people who are not responding to levodopa. Once a person is having good response to levodopa, but a person is experiencing dyskinesias or maybe the motor on-off phenomena, those people are very good candidates for deep brain stimulation, because then they would have the quality of life would be improved for several more years. The only drawback is that this does not delay the progress of the disease. But then recently there are certain studies which are showing that the progress of disease may also be changed to certain extent because of the deep brain stimulation. Things like stereotactic thalamotomy are being used at many places, but the disadvantage of this thing is that it leads to a permanent scarring, a permanent lesion. Unlike the deep brain stimulation, which is basically reversible, once we take out the electrodes stimulating these areas of the brain, the process is reversed. Now, what is new in deep brain stimulation is the presence of a closed loop system is coming, and then the pacemakers which are stimulating continuously 16 electrode channels in the brain, they are coming up, and then it would be possible now to do the programming of the people through internet via video conferencing or from remote locations. So these are the new things which are coming up. Recently, the stimulation of the deep brain stimulation of the globus pallidus internus was approved by FDA. And then there are certain devices like tremor recording devices, which would be worn on hand, or maybe locomotive devices, which a person would wear on his or her feet, and then they would be connected to a pacemaker. So as soon as a person would be having certain gait disturbance, the device would be recording and telling, maybe giving information to probably increase the dose of the drug, or maybe go for any other treatment or some rescue measures. Then ultrasound subthalamotomy. Now, this is also being studied, and it again causes certain permanent lesion in the portion of the brain. But then there could be a subset of people who would be liking to have a ultrasound done on their brains rather than going for surgery. So this would be useful in those subsets of patients. Now, it's known that it was earlier a well-known thing that gait and balance functioning does not improve with the use of ST and DBS. But certain researchers are showing that GPI stimulation could be having better long-term outcomes for those people who are having gait and balance deficits. Then the certain cueing techniques, the use of cognitive movement strategies, cueing using the visual cues, auditory cues, or even tactile cues, maybe they are being used, and then certain cueing techniques are being refined for better management of these patients. Cycling is very useful thing. If a person is able to cycle, then it may be helpful. Treadmill training, robotics, they are all being studied. Now, DBS has been found to have good effect on cognition and mood recently, though earlier the consensus was that DBS may even slightly worsen the cognition. And then trials are showing that even depression may not change, and especially the people who are actually anxious, they may even be benefited with the use of deep brain stimulation. Again, there is some benefit has been shown on sleep, pain, and even the certain autonomic symptoms like urinary disturbance, sweating, etc. The deep brain stimulation of the nucleus basalis of Maynard may be helpful for reducing the cognitive symptoms, for the visual hallucinations, but then its effect on the cognitive symptoms may be doubtful. So these were the strategies which have been employed since long time, like the already known strategies, like the coenzyme Q10, the things like minocycline, certain anti-inflammatory drugs. And what is new in neuroprotective things is exenatide, which is a glucagon-like peptide 1 agonist, which has been found to reduce apoptosis and may probably be useful in preventing the Parkinson's disease. Amongst the rehabilitative approaches, the motor learning strategies performing repetitive movements may be helpful. It is useful to give a clutter-free environment to people. Flexibility exercises using cues, certain strength training, functional training to improve mobility in bed, the use of bells and things to improve the functioning of people. Then telling patients how to get up after a fall, and correcting certain eating impairments, verbal skills, and then ultimately it is helpful to give a message of hope to people with realism, of course, for everything cannot be achieved with treatment. After all, it's a progressive neurodegenerative disease. Certain relaxation exercises, yoga, Tai Chi exercises, lifestyle modifications, how to manage time. So all that has to be taught. Locomotor training, even the cardiopulmonary training. And then there could be certain subgroups of patients who would be benefited more at home with the caregivers, but then there is a subset of people who don't respond to their caregivers very well. The group, the presence of a peer group is what is needed for these people. So group exercises could be helpful. Now, a recent concept is coming up, which is the combination, which is exergame. It is a combination of exercise and games. So even most of us don't like to exercise per se for exercising or for prevention of disease or something more. So that is more common even if a person is suffering from a disease. They may not, elderly patients especially, may not like to exercise at all. So this approach involves the use of games in the form of exercises. So this concept is called an exergame. It may be in the form of certain computer games, or it may even be in the form of certain other games. So it is the exercise-based game therapy which is found to be quite useful. Amongst the lifestyle modifications, certain things have been found by previous researchers to decrease the risk of developing Parkinson's disease, like caffeine, exercise, presence of quality diets, and uric acid. And certain things have been found to improve the outcomes once the disease is developed, like the mind-body exercises and physical activity. And there are also certain things which are found to increase the risk of developing the disease, like pesticides, head injury, and dairy products. Natural remedies, several natural remedies are being tried. A lot of research is getting into this. Things like vitamin B, C, D, magnesium, probiotics may be useful. Fermented foods may be helpful. Avoiding unnecessary iron consumption, green tea, things like Brahmi or Bacopa, and mucuna pruriens, avoiding alcohol and grains, lower protein diet. So these could be helpful. Ashwagandha, grape seed extract, broad beans, and turmeric, fish oils, dark chocolate. So people have studied anything from fish oils, dark chocolates to even mannitol powder. So lots of things are being tried. What's the future like? Future rests on discoveries like the use of nanoparticles, the effect of gut microbiome on this disease, the things like ursodeoxycholic acid, which was till now used for certain other diseases, even salbutamol. And then an important thing is uh, a simple cough syrup, thing which is found in the cough syrup, ambroxol. It may even have certain activities, certain disease modifying effects on the alpha synuclein protein accumulation. So even something as innocuous as a cough syrup may be helpful in preventing the Parkinson's disease. So the take-home message is that Parkinson's disease is a neurodegenerative disease of the elderly population, and for the management of this disease, a message of hope has to be given with realism to the patients and their caregivers. And also, we have to take in mind not only the drugs aspect for management, but also certain surgical things like deep brain stimulation, things like neurorehabilitation, also play a very important role in the management of this disease. Thank you.